Hi everybody and welcome to the BMS Podcast. We all have different perspectives on health, disease and illness that are all shaped by our socio-cultural environment. The aim of this podcast is to raise awareness on different socio-cultural belief systems toward health and promote culturally sensitive approaches in our Western secular environment. Hello and welcome to this new episode of our BMS podcast. Today we're very happy to have with us Dr. Raymond Perrin, who's a registered osteopath in Manchester in the UK, and he's also in PhD. He holds a PhD, and he's a specialist in the treatment of chronic fatigue syndrome, and he developed his own technique of patient management called the Perrin Technique. So we'll talk about all those clinical aspects of this chronic disease and the rationale, the scientific rationale behind manual therapy. And so we're very happy to have you with us. Hi, Raymond, how are you?
Hi, Raphael. Thank you very much for having me on your podcast. I'm very happy to be here. And congratulations on all your Olympic success so far. I've been watching the swimming. You've got this super swimmer. He probably has osteopathy treatment. I don't know who his osteopath is, but I'm sure he must have, especially for the breaststroke. It's not a very good stroke at all.
Thanks so much for being with us. So can you please introduce yourself?
Well, I think you've introduced me, really. I'm an osteopath. I qualified all of 40 years ago from the British School of Osteopathy in 1984. And I've been working as a clinical research scientist in neuroscience for the last 35 years. I graduated with after my BSO qualifications. I went on to the University of Salford when I got my PhD. After 11 years of postgrad study, I did a master's and then I went upgraded to a PhD. So 2 clinical trials and a lot of walking up and down lots of stairs in the university library. It was the days before we had PCs. I came up with a concept that I published in 2005 in my PhD thesis. And this, since then, I've been doing postdoc research ever since at the University of Central Lancashire in Preston, and now I'm clinical research fellow at the University of Manchester. But it's all honorary. Never been paid a penny for my research over the years. I did get a £100 donation from the Enabling Group of Osteopathic Research about 30 years ago, which paid for my floppy disks and my trip to London that I actually received a check. If you remember floppy disks, so that shows my age. So the thing is that it's been a journey of passion, of interest of mine. It's been my sort of hobby, and whilst I've been doing clinical work. So there's very few of us years ago who were doing clinical work and also doing research. In fact, I was one of the first in the country, and probably one of the first osteopaths in the world to be a clinician as well as being a scientist doing research at university level. But my PhD was in involvement of cerebrospinal fluid and lymphatic drainage of the brain in CFS ME, or ME-CFS as we call it now. That's myalgic encephalomyelitis, also known as chronic fatigue syndrome. Now, when I came up with my whole concept, as I said to people, the idea of a drainage system of the brain was completely into the lymphatic system, was completely against medical science. And so when I started, that was the case. And as you will see from talking to you today, we know much different. but I was able to get my PhD on that and carry on. And as they say, the rest is history, as we'll talk about today.
Just for people listening to us and watching us, you've published obviously many papers, and including this book we can see the Perrin Technique.
Yeah.
So that I've been through this this book, and what I really like is that you started. My understanding, and I'm glad you'll be happy to confirm or not, is just you became involved in the treatment of such disease just by clinical observation.
Yeah.
And then just seeking information in the scientific world, establish partnerships with, like you said, at the university level to create just a rational, scientific rationale to understand what was going on. And then you started from that, and then just to improve just the rationale, the clinical science, to optimize the treatments, I would say the frequency of the treatment, all this type of information. So I would say that's an evidence-based approach.
Yeah. Absolutely. Yeah. I mean, this is it. This is what we should do. And I encourage all osteopaths out there, if they have a crazy idea, however crazy it is, you never know.
Yeah, but a few are okay to spend 11 years of postgraduate training just to make sure if this is a crazy idea or not. So,
I know.
congratulations.
Well, the thing is, I mean, when I published in 2005, the lymphatic system of the brain had not been proven.
Okay.
And ME in the 1990s, all the way through, was talked about as they used to call it yuppie flu, that young upward professional people got this, it was just overworked. They needed to get out of the office and do something outside. They were just overstressed. And it was considered very much a psychological disorder. But what I showed there's a major physical problem there in the drainage of the brain. Now, the idea, when they talk about the drainage of the brain into the lymphatics, it was completely, as I said, in 2005, completely against medical science. So when I got my PhD, which was a thesis on this, it was almost miraculous. The University of Salford gave me a PhD on something that didn't exist officially, on a disease that the drainage didn't exist, and on a disease that didn't exist. So I actually got my doctorate on something that didn't actually exist officially. So the question is, what did I say in my thesis that sort of sparked an interest in the orthodox scientific world to allow me to do my research and then get my doctorate and go to postdoc research afterwards? And this was going back to my roots as an osteopath. So when you see when I talk about my work today, you'll understand exactly where I came from. And it wasn't such a crazy idea after all. So shall we start from the beginning and work forward?
Yeah, for sure.
Okay. So right at the beginning of osteopathy, let's start with osteopathy. In the beginning, there was Andrew Taylor Still. And then there was Sutherland, and then it became a profession incorporating cranial osteopathy through Sutherland's work and other Howard Magoon's and other famous luminaries of the old days of osteopathy. But Still and Sutherland both talked about the drainage of the brain. The waters of the brain drain to the lymphatics, said Still. And Sutherland said if you tap the waters of the brain and you'll see by compressing the fourth ventricle, see what happens to the lymph. So they knew, they had an insight that was a almost prophetic insight of the body that they couldn't prove because they had no scientific evidence, and there's no machines and technology that we have nowadays. But they still had this concept. And the reason why it was so against medicine was because you have to look at why we need the lymphatics. The trouble is that most of the medical world don't get taught the lymphatics very well. In fact, very few do. Even the people that think they know about the lymphatics actually know very little. And it's just the least taught system in the whole of the medical world. Even Still said that when he first started teaching osteopathy, he said this to his students. But he said, if you don't understand the lymphatics and you don't treat the lymphatics, you are failing your patient, he said to the students. And they should pass you by as a failure. He said, you have to understand the lymphatics. So the lymphatics was integrally part of osteopathy in its founding days, 150 years ago plus, and then continuing on from that. So, so what Still and Sutherland, why they were so for this was because they realized that they're moving the fluids, that osteopathy is about movement of the fluids. And when we talk about the rule of the artery, the famous rule of the artery, Still said the rule of the artery, but he talked about body fluids. He said it's important to deal with the blood, with cerebrospinal fluid and lymphatic drainage. And most people have forgotten about this. So they call it the rule of the artery, and it really was the rule of body fluids, that we need to keep the fluids moving. When, people say to me often, what's an osteopath? And I say, people say, is it mechanic of the body? I say, we're the plumbers of the body. We deal with the fluids. And it's a much better way of describing. Physiotherapy, chiropractic might be much more the mechanics of the body. We're the plumbers of the body. And you know what? If your house breaks down, if you've got a big hole in the house, you can put a patch in, you can put some wood in there, whatever. If your drainage stops working, you're on the phone straight away calling the plumber out. You need the plumbing, you need the drainage, you need the water supply and the drainage. So this is what we do as osteopaths. We're stimulating the fluids of the body. We do it mechanically, we work on the mechanics, but basically that's what Still was and Sutherland was screaming about. Now, the idea of the drainage of the brain, this was completely against medical science, because medical science for years had a theory that we need the lymphatics. Well, this is true. We need the lymphatics for lots of things, but one of the main reasons why we have lymphatics as well as the blood system is because the blood capillaries can't cope with large molecules. They can take small molecules in through the capillaries, so like a filter system, but large molecules can't get in. So we have a lymphatic system, which their capillaries are like, have gills of a fish that open and close these valves, and these valves allow huge molecules to come into the lymph capillaries and then into the vessels and eventually into the blood at this area here and the subclavian veins. So this is why we need the lymphatics, to drain away large molecules. And so
So what I understand is that early osteopaths had a kind of intuitions on the importance of the lymphatic drainage, but that was 150 years ago. And you said when you finished your PhD, there was no science to support this.
No.
When did scientists became interested in the brain, the lymphatic drainage of the brain?
Well, actually, it goes before osteopathy. There was William Cruikshank in Scotland who talked about the lymph drainage of the brain. There was Speransky in Russia in the 1940s. So there were other scientists talking about it, but they had theories, as with Still and Sutherland, they had theories, but they had no proof. Speransky was the first person to offer an actual area where the drainage could be happening. But let's go back to why science said there wasn't a drainage, and why these few scientists and the initial osteopaths were saying there is a drainage. So the argument is there's going back to lymphatics, is large molecules, and we have no drainage in the brain or spinal cord because we have a barrier, the blood-brain barrier, stopping any large molecules entering the brain. And this barrier is made of tight junctions. Only small molecules like water can get through that, but large molecules can't. And therefore, if large molecules can't get into the brain, we do not need a lymphatic system. But this was all theory until the 1960s. And remember, the spinal cord is a continuation of the brain, and there's a spinal cord blood barrier the same as a blood-brain barrier. So this was only eventually proven by science in the 1960s with the advent of electron microscopy. They could see the blood-brain barrier. And that was it. The end of all these theories about drainage of the brain, because there absolutely can't be. Because there's a blood-brain barrier stopping any large molecules. We don't need a lymphatic system in the brain. So that all went quiet. And during that time, I have a theory about this, about osteopathy, because during that time, cranial osteopathy almost died. Because it was all based on waters of the brain draining out to the lymphatics, and science had proven this cannot happen. However, science is not always correct. and I always think out the box. So any of your viewers who think out the box, keep on thinking out the box. I think out the universe a lot of time. But I was thinking, wait a second. We're told that drainage of the brain can't happen because there's a blood-brain barrier and there's no need for any toxins, large molecules coming in because it can't get in, so we don't need lymphatics. But every second of every day, huge molecules enter the brain. I learned this in physiology. The physiology of the endocrine system, the hormonal system. Every second of every day, huge hormones enter the brain. Because what controls the hormones is the hypothalamus. And it controls it, as I was taught, and is accepted by a mechanism called biofeedback. Hormones enter the brain, and then they send messages back to the organs, usually via autonomic nervous system, by sympathetics and parasympathetics, back to the organ, and that will control the amount of hormones being produced by the endocrine system. So let's look at insulin. Insulin is produced in the pancreas. It goes into the blood, up to the brain, and then in the brain there's a hypothalamus with insulin receptors that measures that, sending them messages via autonomic system back to the pancreas to produce more or less insulin, and that keeps the sugar levels balanced. Insulin is a huge molecule. Water molecules are only 18 Daltons large. Dalton is the measurement of a molecule in science, named after John Dalton from Manchester, by the way. Wave the Manchester flag. When you come, Raphael, when you come to Manchester, if you go to the centre, you'll see John Dalton Street.
Okay. Thank you.
But there's so small molecule, 18 Daltons is very small. But we're looking at insulin, 5,808 Daltons. It's huge, and it gets into the brain. How? Surely the blood-brain barrier stops molecules that size getting in. No, there are gaps in the blood-brain barrier. I knew that, and now it's been shown there's 7 circumventricular organs, 7 circumventricular organs in the brain that allow huge molecules to enter. 2 of them in the hypothalamus, and there's a pineal gland, and there's subfornical glands, and there's other glands which not glands, but other areas of the brain that allow huge molecules in the form of electrolytes, salts and sugars. So there's massive gaps in the blood-brain barrier. So then huge molecules of toxins can get in as well. And therefore we need a lymphatic system. So this was the rationale behind my my fight to prove this, because I knew it must exist. And so did these scientists, whatever reason they had, presumably similar reasons, they knew it must exist. And then it was discovered, so when I published, the theory was that it went through the perivascular spaces or the paravascular spaces, spaces around the blood vessels in the brain. And this led me on my research into this area. But unfortunately, when I published my thesis in 2005, there was no scanning techniques that could show the paraventricular, paravascular spaces next to the blood vessels. We couldn't show this. We had no scanning technique to show this at the time. So again, it was all theory that the drainage was occurring through these spaces, out mainly through the cribriform plate in the olfactory pathway, some through the, again, some major drainage through the eyes, through the trigeminals, and through the auditory pathways. But all the cranial nerves, including the vagus, have blood vessels supplying them, and they have these paravascular spaces that drain off and perivascular spaces that drain off the toxins outside the brain. These are also known in the brain as Virchow-Robin spaces. Some of you might know of it, that name. So these spaces are full of cerebrospinal fluid, and they drain off the toxins. And it was only proven 7 years after my thesis was published in 2012 that they used new technique, dual photon emission tomography in Rochester University in New York. They showed in mice, wasn't humans, but they showed in mice that these spaces did drain cerebrospinal fluid into the lymphatics. So this is the beginning of the validation for my work. I had to wait to 2012, and I started it in 1990. Started my research in 1989, so I had a long wait.
So you've stick to your intuition through this journey. So
Yeah.
I can imagine you had many struggles with colleagues or.
Oh yeah, absolutely. In my lectures, some scientists absolutely walked out of my lectures and said, "You charlatan, this is nonsense. We're neurologists, we're neuroscientists. There's no drainage of the brain." So anyway, again, even when it was proven in 2012 and called the glymphatic system, the lymphatic system of the glial cells, by Macon Nedergaard, who was the professor in charge of this study, even then, there's still a lot of people saying, no, it's only a mice, only a mice. And I was at an osteopathic conference when a leading osteopathic professor, when I told him about the drainage of the brain in humans, later on, he said, no, it's only a mice. So we had to wait to 2017 to show it was in humans. And then they eventually scanned the brain with techniques so they could see the glymphatic system existed in humans. And that was in 2017. We went on further. During that time, they discovered that there were actual true lymphatic vessels in the jaw, in the meninges, actually true lymphatic vessels. So that was an extra drainage system that nobody knew about. We have found out just recently, last year, they discovered the existence of the slim, an extra membrane part of the meninges, dividing cerebrospinal subarachnoid space into two that nobody knew about. So the rubbish goes into the outside, and the good stuff is replaced in the inside of the slim. But if that slim is damaged by trauma and by problems and infections and inflammation and all sorts of things, then toxins will continue to go back into the brain, which causes all these conditions. So nowadays, there's so much science to back up. And then there was another discovery just this last year as well, showing that there was actually tube canals down the neck that nobody knew existed, that you could see with just a magnifying glass. You don't need a microscope. And Joel Pesser was a Texan plastic surgeon who discovered this, and he followed, after his retirement in Texas, he decided to do a few examinations on cadavers, and he used to see these canals, just canals, no muscular tubules, because the lymph has smooth muscle controlled by sympathetic nerves. And this became part of my theory, that as the drainage wasn't working, it wasn't that it was not working because there was damage to the lymph, it was that the sympathetic nerves controlling the lymph were pumping the wrong way, were pumping the lymph back into the brain and into the spine. First we had to prove that there was a drainage system, and then we had to show what happens when it doesn't work. And this has all been done now. We know when it doesn't work, lots of things happen. But Joel Pesser discovered that there's tubes draining out from the cerebrospinal fluid, from the subarachnoid space, directly into the bloodstream, and they're just canals, and controlled by gravity. So if you're sitting up, you drain more. If you're lying down, you don't. And very severe patients who are lying in bed and they can't get up, they're actually stopping the drainage occurring properly because they're not sitting up. And it's not because, and when they sit up for more, people say, oh, you're getting better. They're getting better because they're sitting up. So again, my techniques help the drainage of people who can't sit up, we drain off. So this is very exciting, because we've just in this year alone, South Korean scientists, using scanning techniques that haven't been used before and we're not been able to do these things, they've shown that the drainage of the brain mostly occurs in the cribriform plate area into the lymphatics. So we've got the whole pathway. There's a nasopharyngeal plexus of lymph under the nasal canals that drain 50% of the lymph drains through these pathways into the lymphatics of the neck. Then Joel Pesser's discovered this drainage system outside the blood, these canals. So
thank you for sharing this historical thing, and I think it might be quite funny to observe that years coming and the new publications are just confirming what your intuition was. Yeah. So I would say the following questions would be, know that you have clearly explained the scientific rationale to study to describe osteopathy as a plumbery. How is this? Is there any clinical signs of pathology signs? How can we impact this abnormal lymphatic system?
Yeah. So that's exactly it. So the next thing you have to ask as a scientist, you've got the science. It was all theory, remember, and now it's more factual. But when I first came up with this, it's a nice theory, but what's the evidence there? You need the evidence in the body to show this. So the first thing we saw is that every single patient with ME has a postural problem in the thoracic spine. Thoracic spine is the area that the sympathetics chain comes from, and it drains down all around the body. The sympathetics send messages and receive messages, and this is the thing, it's more receiving, more afferent than efferent. And now we know the autonomics are much more afferent than efferent. There's about 80% afferent going into the spine. So it's the dorsal root ganglia we need to look at. And if we look at the dorsal root ganglia, we've seen now evidence of toxic buildup there, inflammation buildup in patients with ME. Post-mortem of people who've died with chronic fatigue syndrome have shown there's a buildup of inflammation in the posterior ganglion, in the sensory ganglia, in dorsal root ganglia. But from an osteopathic point of view, we can't see that, we can feel it. So what are we feeling? First of all, we feel heat in the thoracic area. We see a spine, we look, observation and palpation. Mr. Noire, who used to teach me palpation and observation in the British School of Osteopathy. We used to have sessions with this wonderful French osteopath. And he also did observation and palpation. And we used to watch, and it's so important to observe and palpate. Famous doctor Abraham Verghese in Stanford University is one of the professors, has written books, and he was lecturing in Stanford. He said, the doctor's round, he was talking to this conference on ME, chronic fatigue, and he said, the doctor's round has become square. So he said, we don't actually look at patients and feel patients anymore. Observation and palpation has disappeared. He said, we all look at just screens all the time. And I went up to him and said, I'm an osteopath from Britain. We do practice observation and palpation, and that's what we do. And he said, you're a rarity in this country. In the US, unfortunately, most of the osteopaths are surgeons or doctors with drugs. Very few of them actually observe and palpate. They're taught to, but in clinic they don't do that. And I said, unfortunately, you're right there, but in England we do. And this is so, and in Europe we do, and the rest of the world, hopefully, we do. And this is the thing, if you observe, you see signs. So the physical signs of chronic fatigue syndrome I discovered many years ago. I found 5 major areas to look for and feel. And you can feel the heat in the thoracic spine, you can feel flatness in your thoracic spine. And very briefly, very new, just 2 weeks old, I made a new discovery.
Okay, thanks for sharing that with us.
This is a new discovery, is that I was given a present of neodymium magnets, magnetic discs, very strong magnets that are used for therapy. They can put them on, if you've got an arthritic finger, these put on and it helps. So one of my theories is that, basic theory is that the buildup of toxins in the brain and the spinal cord is lots of different reasons. One of them, the main reason, is toxic buildup post-viral or post-infection, cytokines causing inflammation. But there's also environmental pollution, including heavy metals, which are attracted to fat of the nervous system, and that's why they're lipophilic, we call it, and that's why they're neurotoxic, like mercury. And mercury is very neurotoxic. There's aluminium. Now, these are ingredients that used to be in stockpiled vaccines. So if you take a vaccine and you inject it, you take it out and it drips on the arm and the top. Some of it will drain away and just stay in the fascia. Won't drain off completely. If you take these neodymium magnets, you can stick it to the arm. And that's in virtually everybody around this area. You take this magnet and put it on your arm, Raphael, in this area. Okay. You'll do it. I'm going to be showing this in future seminars. But with ME patients, what I thought, well, if I'm right about the thoracic spine being the main drainage problem in ME patients, and also the cribriform plate being, the fascia over that will be filled with lots of heavy metals from toxins from an environment. And if I take these magnets, it should stick to the spine and the forehead. And in my new book coming out in November on long COVID, I managed to get these photos in. And I've got photos of patients, the first 20 patients, I've got picture of patients, which I show my lectures. Unfortunately, not for internet use, these photos, but I've got 2 photos that are coming into my book, which will be seen, and the patients are given permission for this, and it's stuck to the forehead, and it's stuck to the spine, and all these patients, and with non-ME patients, non-fibromyalgia patients, and none are patients without neurolymphatic problems, like no long COVID, healthy ones, it doesn't stick. And it doesn't stick much to the lumbar spine, it's the thoracics in the middle. It just sticks to it. There's a magnetic pull. And so people say, oh, well, mercury's not magnetic, not very magnetic, but if it's mixed with the heme in the hemoglobin, it's full of iron. If you have an iron mercury alloy, it becomes magnetic.
Wow.
So there's a lot of magnetism in our bodies from non-magnets, but then become magnets because they're mixed with iron. Is the largest metal in the human body because of all the hemoglobin, but there's also and iron's very important for the body. But there's also another thing. If I go back to my physics, it's all based on physics. The whole of, my ideas of the cranial, which I'm going to talk about shortly, it's all based on physics. But if you remember your physics of electromagnetic fields happen when you have one coil of one metal and a coil of another metal, and you put it between the two, a rod of the other, it creates an electromagnetic field with a north pole and a south pole. That's happening in our bodies all the time. If you have a buildup of these metals, as they twist round each other, they create different small, minor, little electromagnetic fields everywhere, which are magnetic. So you take a magnet and it will attach to these. And if there's a buildup of these heavy metals in areas which aren't draining away, you'll see it. And we're seeing this in virtually every patient. The more severe they are, the more magnetic they are. So it's one of the extra bits of my work now we're looking into. We're probably going to do some new research into this very soon. So watch this space. But it's interesting. Again, it's observation. It's just clinical observation. And it was based on a patient telling me that she felt magnetic and she's tried it on hers. I said, well, let's try it on others. Let's see. Wow. So we did. So that's it. And this is how my physical science came around. So the spine was the first one. When I noticed a redness, there was irritation there was sympathetic irritation, and there was heat. There was sometimes trophic changes based on cause work, showing when there's nerve damage, there's trophic changes in the skin. And then we looked at the lymphatics. So if the lymph is pumping the wrong way, and sometimes pumping the right way and then pumping the wrong way, it's through sympathetic innervation going wrong, because the toxins are all being built up around, we now know, around the hypothalamus, around the thalamus. And the hypothalamus is the main control of the hormonal system, which got me on my theory, but it's also a balance mechanism for the autonomics. If we're without the hypothalamus, your autonomic nervous system wouldn't be balanced. You need the hypothalamus to keep the balance. I say it's like walking a tightrope. And this is what helps us cope with what we call allostasis. And allostasis is a much better term than homeostasis. Homeostasis means everything's balanced, everything's nice, no problem. We're sitting on a nice chair, all balanced. None of us are like this. None of us are sitting on a nice chair in a lounge, talking to a good friend in Paris. We're walking on a tightrope the whole time, the whole time. And we're trying to keep balance. That's allostasis, because we're being attacked from all areas, from external means, internal. And the hypothalamus is doing this grand job of keeping everything balanced via the autonomic nerves. So if the sympathetic nerves, which control the lymphatics, go wrong, and we were taught that lymphatics don't have a nervous system. When I was studying in physiology, we were taught they're just tubes. There's no nervous system attached to it. Now, we definitely know. And it's been known for years. It was known in the 50s. We just weren't taught it. That the sympathetic nerves attached to all the lymph collecting vessels, and they have smooth muscle walls that pump one lymphangion, as it's known, to another, and to another. And this pumping mechanism goes one way because the hypothalamus balances it all. But if the hypothalamus is being poisoned and it goes out of balance, you get it going one way, and then the other way, and then one way, and then the other way. And these vessels, the valves get damaged, and they get bigger and bigger and bigger until they come to almost 10 times, some of them, the size they should be. And this is what my second finding was. When I was examining patients, the drainage of the brain, the drainage of lymphatics should drain all into the venous angles, where the internal, so you've got the internal carotid, and the internal jugular vein, and you've got the subclavian vein where they join. That is where the lymph joins. That is where, can you hear me? Yeah.
Yeah.
So that is where the lymph is lymph vessels drain into the thoracic duct on the left side, mainly on the right. Right, you've got the right lymphatic duct. But those ducts, when they go the wrong way, when they pump the wrong way, they're pumping the lymph out into the system, into the tissue. So lymphangions in the subcutaneous fascia, the closest to the skin, these lymph collecting vessels, they should be 0.5 millimeter wide, full of colorless fluid that you can't see. So in a health, you can't see them, you can't feel them, they're too small. But what I was seeing, what I was feeling, is that these patients all had these vessels. You could see them, you could feel them, but you couldn't see them because they were colorless. Lymph, the fluid in lymph is different to blood, it's a colorless fluid. And I could feel them in all patients. And then one day I got lucky and a patient came in where you could actually see it. So I took a photo of it and showed it at the next conference, to which an American professor came over to me and said, "Gee, what equipment did you use to get this amazing image?" So I said, "A camera." It had to be some $1 million equipment. It was just a simple camera. And so this image was the first physical evidence ever of varicose megalymphatics. And it was originally talked about by John Kinmont, the professor, 20 or 30 years ago, talking about megalymphatics that he saw as a surgeon, but he could never prove they existed in any scans because the scans were all told by his colleagues to be scans of veins, not lymph. But we could see this very clearly. So this was real, but we could feel it in all patients, and that was the second sign. Then when I was examining the chest and breast tissue of these patients, I noticed every one of them had a tender point. And this tender point was lateral and superior to the left nipple area, around the left side on the chest. And this was related to a whole sympathetic irritating sensory nerves, and from the cardiac plexus and from the thoracic duct. Together, they irritated the nerves that the afferent sympathetics irritated the sensory nerves that eventually caused this painful spot in every patient I saw. Every patient had this spot. And this spot then became known as Perrin's point because I discovered it and it didn't have an anatomical name. So I put my name to that spot. So this spot now is now in papers and it's in books and it's been researched by other scientists, and it definitely is there in all these patients. And we see this in long COVID as well. So this is a third sign. The fourth sign was the tenderness in the celiac plexus because of sympathetic irritation in the abdomen or lower down. And then the fourth sign of the fifth sign was the cranial rhythm was disturbed. So what was that? And then this came to my paper of 2007 when I published a paper in the American Journal of Osteopathic Medicine, now called the International Journal of Osteopathic Medicine, I think, isn't it? Or International Osteopathic Journal, IOJ. So the American Journal published my paper on the theories of what the cranial rhythm is. Because when I was taught in the BSO all those years ago, we were told about the cranial. And we asked, what is it? What is this rhythm we're feeling? It's around 8 to 12 beats a minute, but what is it? Nobody could give an answer. They said, we think it's this, we think it's that, we don't know. And I found with my work, I was lucky to stumble upon what actually is going on based on physics. Cerebrospinal fluid in the brain is produced by the blood and goes back to the blood. And if it's not working correctly, it will sort of, the movement will be affected, the drainage will be affected, but we thought it all goes into the blood. The original model that we were taught in college was the cerebrospinal fluid is produced by the choroid plexus in the blood, the arterial supply to the brain, and then it goes back to the venous sinuses through the arachnoid villi. That was it. That was the drainage of the brain. What we now know is completely different. And once you knew it drained into the lymphatics, the main duct of the lymph, Professor John Kinmont, as I mentioned earlier, discovered that the thoracic duct has a pump of around 4 beats a minute. So it starts in the blood, so it starts at 50 to 100 beats a minute, the cardiac pulse, and it goes into the lymph eventually, and most of it now we know goes into the lymph. That then, the lymph has a movement, the main central lymph, of 4 beats a minute. When you have a very fast wave going together to a very slow wave, when they cross together, when they meet, it causes an interference wave. That is physics. It's just pure physics of hydrodynamics. And we have physics going on in our body all the time. Our body works under the laws of physics. So cerebrospinal fluid draining to the lymph causes a third wave. And that third wave osteopaths call the cranial rhythmic impulse. And that is always disturbed
You
with...
describe this in your book as the waves on the shore. So I really like this kind of explanations. And
yeah. Because everybody's seen it. You see a big wave coming in, a small wave going out, crash together to produce a third wave. You don't need to be a science to understand that. But this happens in our bodies all the time, and we call it the cranial rhythm. So when I published my paper on the physical signs, we published we did a blind control study on it, and we showed that there was 86% of our patients using 2 practitioners showed these signs were there. It was an 86% accuracy in some of the signs. And we had a doctor looking at these patients, didn't know, they couldn't speak to the people, and then didn't know who was patient, who was control. He only got 44% of the ME correctly diagnosed. Using just the physical signs, we got 86%. So it was published in the British Medical Journal, and all the early cranial osteopaths who are sadly passed would be happy to know. I was speaking to an osteopathic when I was training people in New York recently and giving a lecture in the Cork Osteopathic Conference in New York. He said Viola Fryman would have loved to know that the cranial rhythmic impulse was mentioned in the British Medical Journal and not so we were published in the BMJ, and they didn't even question it. It's physics. They understand it. It's physics.
Yeah,
So
congratulations for that, because I, as you know, there's a lot of controversy on cranial osteopathy, as if this is just something exactly outside the scope of medical science for the moment. But many people had intuitions, and many people have observed that's the most important for me, that it can be related to some conditions, and patients' conditions can improve after some manual treatment. So
because we're draining this glymphatic system. So the glymphatic system now has been proven gives much more credibility now, and this way it comes back to the most amazing piece of information for osteopaths. First of all, I mean, the Perrin technique was developed very simply to do the job that the body wasn't doing. So these patients don't have a healthy glymphatic system. They don't have a healthy neurolymphatic system. So we can stimulate it by cranial techniques to stimulate the glymphatics, and then stimulate the lymphatics once they come out the brain using manual lymphatic techniques that I developed, draining down to the collarbone, draining up to the collarbone, creating a concertina effect, an accordion effect, pushing up, pushing down, draining off the toxins, and getting the spine moving better as well will help the drainage of the toxins out from the spine. Once the drainage works better, there's less toxins irritating the hypothalamus, which then kicks the sympathetic nervous system into working more balanced, and then the lymphatics work in a more basically a healthier way and continue the drainage. And when we do the drainage, we create a siphon effect, and again, based on physics, you create a pressure differential that creates it's like a suction effect that goes into the main venous angles and continues on this drainage, draining off the spine, draining off the brain. So that's how it translates into osteopathic care. And that's why I'm saying osteopathy is based on science. And that's what I've shown in my work.
Thank you again for sharing all of this very insightful information. If we have colleagues listening and watching us who might be interested in getting your specific training, how long does the whole training last?
Well, we have courses. There've been two-day courses. We're now on to 3-day courses because there's so much science to back up everything. And it takes time to understand all the coursework. So we have a 3-day course, okay, mostly looking at the science behind it and how the diagnosis works, why we do it this way, all the details of the science, what's known about ME, CFS, fibromyalgia, and now long COVID, and other conditions like Lyme disease, which is neuroborreliosis, which is very similar, and even lipedema. There's a lot of people who have cognitive problems and brain problems with these conditions. So we go into a lot of pathophysiology and anatomy, making sure that they understand what they're doing, and then we do the train up in the diagnosis and the treatment. So it's a 3-day course. We have them all over the world, and hopefully we'll be coming to Europe a few times next year. It's on the website, on the Perrin Technique website, that I have courses that have been already booked. And if you, I'm giving a course next month in Alaska. So if you want to come to Alaska, there's spaces for the Alaska tour. I'm going Anchorage, Juneau, and Fairbanks. I'm doing Minneapolis. It's a lecture tour in Minneapolis, and also Olympia. And Minneapolis, Olympia are full. In fact, Minneapolis, there's so many people want to come to my course there. They've asked me, can I do another one next year? Because it's normally 20 people maximum, and they've got 27 booked into the Minneapolis course already. Okay. And they want to, and there's more wanting to come to it. So it's my work is taking off in the States, but Europe I've just spoken to you know him, there's a good friend of ours, Yuri Powell's, and Yuri's set this wonderful new college up in Belgium, and I've been there once. I'm going there again in May next year. I'll be going to Germany to do workshops, and also Athens in Europe. But hopefully I'll come to Paris if there's a group of practitioners.
We'll think about organizing.
Yeah. So I'll come to Paris. I love the city, and my wife and I have spent some lovely times in Paris. So hopefully I'll be able to train up as many people as want to learn, because the techniques are so, and this is where the pièce de résistance to my whole work comes back to Sutherland, when he said, when you tap the waters of the brain, when you do a compression of the fourth ventricle, see what happens to the waters to lymphatics. In MIT, just a couple of years ago, Laura Lewis, a neuroscientist, and her lab showed that the reason for the pressure buildup that allows the glymphatic system to work during delta wave sleep mainly is deep sleep. But what happens then is during deep sleep, there's a 10% reduction of blood volume in the brain. Now, wow. Monroe Kelly doctrine says the brain is one unit made of blood, cerebrospinal fluid, and tissue. So if blood goes out of the brain and reduces by 10%, it's got to be replaced. The only thing that can replace it is cerebrospinal fluid. So she's found that cerebrospinal fluid goes into the brain, in the fourth ventricle, it gets sucked in, it creates a pressure there, and the compression of the fourth ventricle, this is a neuroscientist not knowing anything about osteopathy before she did this work, compresses the ventricles and out into the glymphatic system and out through the system. And therefore we have proof of Sutherland's original theories that the fourth ventricle compression leads to third ventricle and lateral ventricles compression, but this leads to the cranial rhythm. as we call it, the neurolymphatic system, the glymphatic system.
Wow. And any clue on how they get this kind of intuitions? Because they didn't have any
Well,
less
yeah,
evidence than we have today. So this is
they were doing I don't know. I really would love to meet some of the historians. I'll go hopefully to Kirksville one day and meet some of the historians
okay.
there. We have John in England, who's a good historian. Maybe somebody out there knows exactly what. Maybe they're thinking my way. Hormones every second of every day go into the body, into the brain. Maybe they realise that as well. I don't know when that was actually discovered or theorized, but maybe that was it. It's yeah, but it's been an incredible pathway, Raphael. I tell you now, it's very exciting times now with the new advent of these new techniques and a new science. And I've now been there's a person who's funding a research centre we're building in Cambridge with a 3T scanner, and I'll be doing some very interesting research on the slim, on the glymphatics, on all these areas when we've got the scanner up and running beginning of next year. But so there's a lot of research to come, and we'll also look at any biomarkers that could show the lymphatics and show the sympathetic nervous system's not working well. We can do a lot of very interesting research in the future. Yeah, but I'll show you. You know, I said that you and I, when we were taught about the drainage of the brain, we were taught it was through the arachnoid villi into the venous sinuses. That was it. That was the drainage of the brain. But I've drawn a picture from my new book, which is going to be drawn better by a professional artist. But I drew this sketch which shows the drainage of the brain as we know it now. And I have it, if I can share my screen. And I have it if I go.
For sharing that with us.
I will show you this now if I can find it. Sorry. So first of all, this is one picture. I don't know if you can see. So this is a slim. Now we know. So we never knew about this. We now know that there's that the subarachnoid space has these trabeculae, but there's a divide by this slim. In the outside, there's all the cerebrospinal fluid with all the gunge, and all the pure cerebrospinal fluid is inside. So that's what we now know. We know there's lymphatic channels going through, true lymphatic vessels going through the jaw. We never knew that before. So that was one slide that I showed, and I just want to show another one. Soon stop sharing. I just want to find this other one because it's so interesting. If I can find it, desktop. I've got it here somewhere. There should be a picture of coloured. Sorry, drainage of the brain in colour. This is it. Okay.
So
now,
next number you say, but the release of your book.
Can you see this? Share? I don't know. Share. Can we
No.
see this? Oh, no, I can see it now.
Yeah.
See that? That is now what we know about the lymphatic drainage of the brain. We have this extracanalic system. We have the glymphatic system draining off into the outside of the slim. We have the glymphatic system draining through the membranes, through the meninges, into lymph vessels outside the brain. We have a major drainage plexus of lymphatics through the cribriform plates, and underneath you've got this massive nasopharyngeal plexus that is the main 50% of all drainage of the brain occurs in this area, and the blood flow is a small bit of it now. So this area where we thought the arachnoid villi was the main drainage, was the only drainage of the brain, we now know is a small part of the whole picture. It's quite, as you're the first, I know this is my own sketch, so, but it shows basically all the different parts of the picture now. So it's a schematic. It's not actually what the brain looks like, by the way.
Well,
Anyway.
thanks so much for sharing this those pictures with us. We're getting close to the end of our chat, but I wanted to discuss one important point, something that I've read in your book.
Yeah.
So, according to your experience, chronic fatigue syndrome might be a predictable disease based on observation and palpation.
Yeah, absolutely. Yeah.
And I'd like to know more about that, because if this is true, if this hypothesis is true, so osteopathic care might be a preventative treatment for this type of patients without any symptoms, but just based on case history, observation. So some patients might be more prone to develop this type of the disease in the future.
Absolutely, and we see it familial. There's a scientist who works in Barcelona, Jesus Castro, Professor Castro, and his team found that 15% of ME patients, it's familial, it's in the families. And I see this again and again and again. In chronic fatigue syndrome, you might see fibromyalgia in your clinic, in families, it runs in families. And long COVID as well, we're seeing the same. And remember, it affects women, these conditions affect women more than men because of hormonal changes that we see because of the hypothalamus. Also, the cytokine buildup post-viral, it's cytokines. One of them is one of the cytokines that has been shown to be really predominant in ME by Professor Jared Younger in Alabama. He showed that leptin is a adipokine, a cytokine that actually goes up and down. This affects the satiety and hunger of a patient, and is very much a female hormone. And also you've got breast tissue that gets congested much more in women than men, which causes a lot of irritation to the nervous system and the lymphatics. Those are the three reasons why women get ME much more than men. So when I wrote the paper Into the Looking Glass, which I wrote on the day that the pandemic was announced in COVID, I said there'll be a post-COVID syndrome affecting women more than men, because I knew it was happening already with ME patients, and it was going to go through the olfactory bulb into the brain. So the anosmia, they get loss of smell, and then they get fever because it hits the preoptic nuclei of the hypothalamus, which stimulates fever. And I said all this in 2000, on the day that the pandemic was announced. I wrote this paper, and that was called Into the Looking Glass. It was published a few months later, and now my book comes out called Through the Looking Glass. So you can predict if people were going to get the long COVID if they had the physical signs. It's never the virus. It's never the Epstein-Barr virus. It's never the COVID that causes long COVID. It's never the virus or infection or trauma that causes people to have chronic fatigue syndrome or fibromyalgia. They get it as a build-up, and it's happening for years and years. And this build-up causes these signs. The flatness of the spine, if they're very active, the spine won't develop in the right way. They get osteochondrosis, Sherman's. They get problems in the lymphatics, so you can feel these varicose lymph, megalymphatics forming years before the symptoms, and you can feel most of the signs are there. The tenderness in the chest and the tummy, and the cranial rhythm definitely is sometimes affected from birth. And we see firstborn breastfed babies more likely to get ME than non-firstborn their siblings, and this is because their firstborn trauma to the head, as we all know, is much greater in the firstborn, and if they've had forceps or fundus, there's even more chance of problems in the cranial rhythm, and that's a major problem affecting the drainage. So years later, if they've got all these signs, one final trigger will stimulate the disease. So if we can spot that as osteopaths, if we're treating one patient, maybe their children have also got some signs as well. And we can prevent it by doing techniques to drain off the toxin, to get the cranial flow working better, stimulating a healthy cranial rhythm, get the spine moving better. They'll never get the illness. And I've seen a lot of patients like this over the time whose family members have similar early symptoms, and we stop it there and then. and we prevent it. The trouble is, we can never do research to prove this, but
Yeah.
but we know as osteopaths, we do this all the time in clinic. When people say, or I say, oh, you've got a problem there, and you say, I've got no pain there. He says, no, but if you just leave it, it's going to cause major problems, and you treat it, you prevent them getting these major problems. And the same thing with ME. And so I'm the only person in the world that says you can actually prevent ME if you and many of these conditions as well. Who knows?
Wow. Thanks so much for this wonderful chat, because I really enjoy talking to you, because you talk about osteopathic principles, you talk about early osteopaths, but in the context of the science and the what the intuition they had that have been confirmed later. And you talk a lot about science, but science and clinical practice. So how can we improve the manual treatment? How can we improve the diagnosis, the observation? Because in my practice, I certainly have missed many of the observation simply because I wasn't aware of that. But since you're able to publish in peer-reviewed papers the observation and the accuracy of to diagnose CFS, that's something really, really wonderful. So thanks so much for sharing your.
My pleasure. My pleasure.
I'm really impressed, because I can imagine all the struggles you had to endure just following your intuitions that something has to be there. There's a missing piece of the puzzle that might be able to explain all those symptoms, and more importantly, that like you said, with observation and palpation, we can improve such conditions. So
absolutely.
thanks so much. Do you have a final words for
final
people?
words is for any young osteopaths out there? First of all, treat back problems, treat joint problems, fine, but don't be afraid of going a bit out of the box and seeing if you can help other conditions. And also, if you have an idea and you want to take it further, don't just think, oh well, there's no point, it's going to take so long. I've been doing this 35 years, and it's worth it. Some ideas never pan out, some ideas never get validated, and sometimes you're wrong. But as long as you're thinking and you're trying to increase the scope of osteopathy, then we'll do some amazing things. And it was Orville Wright said, the first who invented with his brother the first flying machine, the plane, or the Wright brothers. He said that if everything that you accept is true, if you accepted everything you're told is true, you accept it is true, then you would never be able to go further and develop new ideas and new concepts and further science. So he said it in a different way, but he was a giant in the obviously we wouldn't be flying around the world if it wasn't for people like Orville Wright. So and osteopathy is been here for 150 years, and who knows what we can achieve in the next 150. So that's my final message. Thank you very much, Raphael.
Thank you so much, Raymond. See you soon. See you
soon. Yes, so Raphael's is one of our guest lecturers at the Perrin Technique conference for Perrin Technique practitioners only, sadly, but there's a lot of us around, and that's in Manchester in December. So looking forward to welcoming you there. So anyway, we'll speak soon. Take care. Thanks a lot.
Bye. Goodbye.
For now. Bye.
Thanks for listening to the BMS Podcast. We hope you've enjoyed your chat today. BMS Formation is working to bring more compassion and tolerance between people holding different worldviews in healthcare and beyond. Share it if you like it, and see you soon.